Now we're going to conclude with the final part of our poisoning lecture. And so to summarize, we have a 29-year-old male presenting with altered mental status after suspected intentional overdose of Ativan or lorazepam, Tylenol or acetaminophen, oxycodone, and ethanol. We've put it all together as a poisoning case. The patient took benzodiazepines, opiates, ethanol, acetaminophen. He has elevated LFTs, a normal CT brain, and a normal basic metabolic panel. We know based on this that he's likely an opiate, benzodiazepine, acetaminophen, and ethanol poisoning patient. We know the benzos, the opiates, the alcohol, the acetaminophen, and we also know that he has a normal osmolar gap, ruling out toxic alcohol ingestions. And so now we want to think about poisoning. So how do you treat poisoned patients? It's important to address their airway, breathing, and circulation, which we did as soon as the patient came in. And the treatment for many poisons is simply supportive care. We considered GI decontamination, but this patient was not a candidate for this. And now let's talk a little bit about antidotes. So we know the patient was an opiate poisoning patient. For supportive care, we know the patient had respiratory depression, for which we intubated the patient. We know he was hypotensive, for which we gave him IV fluids. But the antidote for opiate poisoning is naloxone. We tried this when the patient first came in, but because he also had sedative hypnotics and ethanol on board, it was unlikely that he would react to this fully, and that's why he didn't completely wake up. And so it's important to remember, if you give naloxone, the half-life of many opiates is longer than the half-life of naloxone. So imagine if this patient were simply an opiate overdose. He may have woken up when given naloxone, but there's a chance that several hours later or several minutes later, he may become more sleepy and somnolent again. It's important to remember to redose the naloxone if necessary. And it's also to remember that if you suspect an opiate overdose, you should try naloxone prior to intubating the patient for respiratory depression if there is time. Oftentimes, giving naloxone will completely reverse the patient's opiate overdose and prevent you from having to intubate the patient. What about benzodiazepines? So for supportive care for this patient for his benzodiazepine or lorazepam and ethanol overdose, we intubated the patient and gave him IV fluids. The antidote for benzodiazepine overdose is something called flumazenil, but there's question of whether you should use this or not. And the reason for that is because flumazenil can cause life-threatening seizures in patients with chronic benzodiazepine use. It's rarely, if ever, used clinically because oftentimes you don't know if the patient is a heavy drinker chronically, if they're chronically on any sort of benzodiazepine. And in this case, we do know the patient is a heavy drinker, and we do know the patient is on lorazepam chronically for anxiety. So flumazenil in this patient could very easily lead to life-threatening seizures and should not be given. And then what about alcohol? So for supportive care, we intubated this patient, gave him IV fluids, and there's no real antidote to ethanol ingestion other than time. And this brings us to our next red flag. So we've addressed 3 of his toxic ingestions, but we haven't addressed the acetaminophen. And so acetaminophen has a very specific antidote that's very important to give in toxic overdoses. And that antidote is N-acetylcysteine. And so in acetaminophen overdose, supportive care is not enough. You must give N-acetylcysteine. And so let's think about acetaminophen. So initially, patients with acetaminophen overdose are asymptomatic. Then they begin to have nausea, vomiting, right upper quadrant pain, malaise, and this ultimately can lead to hepatic or liver failure and hepatic encephalopathy or altered mental status. They can become jaundiced and ultimately have kidney failure secondarily to their liver failure. And so the toxic ingestion of acetaminophen, the toxic dose, is 150 milligrams per kilogram. You should draw an acetaminophen level 4 hours after the time of ingestion if you know the exact time of ingestion. It's important to use the Rumack-Matthew nomogram to determine if the level is toxic, if you know the time of ingestion. So this brings us to another very important point. If the time of ingestion or the amount of its acetaminophen ingestion is unknown or unclear or questionable in any way, you should treat with N-acetylcysteine regardless of the acetaminophen level. So here's the Rumack-Matthew nomogram. As you can see, if you know the time point of ingestion and you know the patient's acetaminophen level in their blood, you can tell if the patient is hepatotoxic or not hepatotoxic at that dose. However, oftentimes we don't know the single time point the patient ingested a medication. This is also not useful if the patient is chronically on acetaminophen and this is a chronic overdose. So it's important to remember that the Rumack-Matthew nomogram is useful for single time point ingestions only when you know that exact single time point. It's not useful for chronic ingestions. And so in our patient, we don't know what time he took the medication, so we should treat him with N-acetylcysteine. Now it's time to reevaluate the patient. So in general, the patient localizes pain now when the sedation is off, but he's still not following commands, so you leave him intubated. His airway is protected, he's intubated. His breathing, he's ventilated, he has clear lung sounds, and his circulation shows an improved heart rate between 70 and 80 beats per minute, and a blood pressure that's improved to 110/70 after 1 liter normal saline. And so now we need to disposition this patient. So where should this patient go? You have an intubated patient with altered mental status who was poisoned with multiple substances. This patient should go to the intensive care unit. So you call the intensive care unit and admit the patient. But you need to remember, we have one more red flag to address. This patient was a suicide attempt. He took these medications in an attempt to kill himself. If he wakes up and is extubated, can he just go home? Or does he need psychiatry to evaluate him, to determine if he should be held against his will for further psychiatric treatment? And so we need to make one more consult, psychiatry, to determine if the patient needs to be placed on a psychiatric hold once he's awake and able to talk to us. And so it's important to know your state or your country laws about when and where you can hold a patient against their will. So in summary, naloxone is one of the most useful antidotes. If you have a patient with opiate poisoning, you should consider naloxone because this may completely reverse their toxidrome without needing to intubate the patient. There are some antidotes, however, like flumazenil, that have limited utility and possibly dangerous side effects. Supportive care is extremely important in all poisoning patients, and N-acetylcysteine is life-saving in acetaminophen overdose. The Rumack-Matthew nomogram for acetaminophen overdose is only useful for well-documented single time point ingestions of acetaminophen. You should always treat the patient if the time course is unknown and the exact time of ingestion is unknown and you suspect acetaminophen overdose. And then you don't want to forget about suicide attempts. This patient needs psychiatric evaluation and may be at risk if he's ultimately discharged home. So this concludes our poisoning case. As you can see, with any emergency medicine patient, you approach them with airway, breathing, circulation, and the same triad of evaluating thinking and acting, reevaluating thinking and acting, and then dispositioning the patient. You should always keep a broad differential on any altered mental status patient, even if you suspect poisoning, to make sure there's nothing else important going on, such as trauma or electrolyte abnormalities. And then it's important to recognize co-ingestions, such as acetaminophen, or things with very important antidotes that can be life-saving, and if missed, the patient will ultimately die. So in this case, we have a patient who was a multiple poisoning patient with benzodiazepines, opiates, alcohol, as well as with acetaminophen. Addressing all of these is very important to save this patient's life. And as you can see, with good care and disposition to the ICU, this patient likely would do well and ultimately get the psychiatric care he needed and be discharged home.